known experts in their fields. I'm going to start with Professor Ramez Kirollos, who is now joining us from Singapore. He's going to talk about the vascular anatomy of the anterior, middle, cerebral, and posterior cranial base, which is so clearly important for all of us to deal with any vascular cases. So, Ramez, all to you. The rules are clear: 20 minutes discussion and 5 minutes for discussion. 20 minutes for presentation and 5 minutes for discussion.
Right. Thank you very much, Ramez. Thank you very much, everyone.
For the registrant, they have to put their question on chat, so the moderator will be the sole one who will select from. Thank you.
Thank you.
Thank you very much. I'll cover the anatomical talk. I cannot advance.
Ramez, you must click with your mouse, if you don't mind, on the screen. That's it.
First, I acknowledge Professor Roten's slides that was donated to us, which I'm going to use for this talk, which is mainly anatomical landmark. I will concentrate due to the time on the carotid and relationship to the skull base and the vertebrovascular junction, and the connection between them is really about intraoperative landmarks and orientation, and we'll use the floor of the sphenoid sinus as I will show you subsequently. And now what is important in anatomy is that we have endoscopic skull base, and we have to correlate the view from intracranial and from the skull base to the endoscopic view, which is a bit demanding. So when we start, this is the workhorse for endoscopic skull base surgery. We go through the sphenoid sinus. Once we enter there, we start to get landmarks, the optic and the carotid impression, and it's mainly to find the OCR, opticocarotid recesses, which is the impression between the angles between the carotid, we can see here, and the lateral one, which is well areated in this specimen, and it's where the optic, the strut for the anterior clinoid is. But what is important is the medial clinoid. This is an area above the tuberculum celli, which is here, above the middle clinoid, and it's the corridor to enter the carotid as the supraclinoid. So the talk will go through the carotid artery, as you can see, and its relationship to the clivus and the skull base from the anterior fossa down to the middle fossa. So if you concentrate on this view, which be important to know, forget the numbers, but we will use it for clarifications. The parapharyngeal carotid enters the petrous bone through the carotid canal, has a horizontal part and a vertical part. This is the petrous carotid. It passes around here, which is the foramen lacerum, and you correlate it with the angiogram. First, you find your ophthalmic artery, and then you can correlate the carotid. The fifth nerve is straddling it in 45 degrees with V2 around this vertical part. Then we have another part, which is the fourth segment in this, and at the apex is the meningohypophyseal trunk. So the pituitary gland lies here. And then we have the carotid siphon. And if you concentrate on the number 3, number 4, and number 5, this is numbers means nothing, but just concentrate, because this is where the cavernous sinus will start. The cavernous sinus starts above the V2, so most of the vertical and the vertical part, the C4, and is the all cavernous segment. And it ends where the fibrous ring is here. But then when endoscopy came, we renamed 2 segments. This vertical part to be called the paraclival carotid, while the siphon here is called paracellar carotid. And we don't see this from that view. In fact, this is what you see. So this is the paraclival carotid, this is the paracellar, and this is the entrance. The intercarotid distance is narrowest usually at this point. This is the point that is potential for vascular injury during endoscopy. And as you can see, the carotid is in line with the pterygoid plate. This is in the lateral view, and we can see well-aerated sinus, and you can see the carotid siphon. So this is the paracellar carotid. The paraclival is more posterior. Now, for the other segment, if we look upwards, then we can start to see this segment that is not obvious to us because it's tucked away before where the pituitary is. And you can see here there's the inferior hypophyseal artery because the meningohypophyseal trunk is located here. Now we look from the above, so this is the view, this is the top, the feet is down here, and we have to appreciate that the paracellar carotid is more prominent, while more posteriorly is the so they are not in the same line, as you can see here on the lateral view of an angiogram. Now, if you look from inside and to try to correlate, this is the middle fossa on the right side. So to orientate you, this is optic nerve, carotid. So this is the top, this is the posterior. And then if we peel, we start to get the Meckel's cave and the cavernous sinus, which they are both potentially the same place here. So this is the cavernous sinus, and anatomically, the cavernous sinus starts above V2, although there is an extension, as you can see here. Once we cut the superior petrosal, we can see more of the cavernous sinus. We peel a bit more, we clear it, we start to see the petroclival ligament. Here, this is the Gruber ligament, and this is the Dorello's canal. And then we start to see the carotid. So this is the petrous bone. So the horizontal part is hidden. Then we have the vertical part, and you can appreciate this is the clivus. The pituitary will be located here, and this is the carotid siphon related to the fourth and third, and also here is the fifth. So the sixth cranial nerve is always deep to the V1 and adjacent to the vertical part. So here is the appearance from here, which is exactly correlate when you see from below. So this is how we correlate it. So the paraclival carotid, which is the vertical petrous part here, is equivalent here. So we're looking through the sphenoid sinus, looking towards the left side. And then you can see the paracellular carotid, which is adjacent to this area. And you can appreciate that the V2, which is crosses the paraclival carotid, appears here on the lateral sphenoid wall, and is going to the pterygopalatine fossa. So here is this appearance, and then we come to here. This is the most informative slide of everything I'm going to show you, because we have opened the anteromedial and posterior lateral triangle, and we enter the sphenoid sinus. So the view we get from the sphenoid sinus, here it explains why the V2 appear in the lateral wall, and here what appears the paracellular and the clival carotid. But here we have the deep petrosal GSPN, greater petrosal nerve, to form the Vidian. And the Vidian nerve is emerging at the floor of the sphenoid sinus. So this is the most important view, again, magnified to correlate view from what we see from inside and outside. If you understand that, it makes it very easy to correlate your landmarks, and it's the difficult part we can see. Here we can see the rings, so this becomes the extra cavernous. So the cavernous segment of the carotid included the paracellular, this horizontal part, and most of the vertical part, not all of it. And here again, this is to put it all together and to correlate it with the angiogram. So if you look at an angiogram, you can know exactly which part of the carotid is related to which part of the cranial nerves and which part of the skull base. So that brings us to the floor of the sphenoid sinus. You know, the manubrious terminal angle is important in thoracic anatomy. There is a lot of landmarks, trachea, bifurcates, thoracic ducts, emerges, recurrent pharyngeal. So we use the floor of the sphenoid sinus. It's a concept inspired to us by Dr. Amin Qassam when he visited us for some courses in Cambridge. So what happens in the floor of the sphenoid sinus? At the floor of the sphenoid sinus, there is a lot of events. First, we have the Vidian canal, which I have showed you here. There is another small canal, the palatovaginal foramen or fissure, where it has the branches of the pharyngeal artery, but it is smaller, but not to mix it up with the Vidian canal, which is here. And if you go 45 degrees upwards and superiorly, you get the foramen rotundum. And you can see here the infraorbital nerves coming from the V2. So this is the floor of the sphenoid sinus, which is a very good landmark. And this is why. So this is the sphenoid bone, and here are the Vidian canals. 45 degrees, you can see the superior orbital fissure. This is the foramen rotundum. This is the pterygoid plate. And it correlates exactly with your landmark. So this is a very good landmark for this, but there is a lot of other events happening there. Of course, we have overlying it when you do surgery, articulation with the ethmoid air cells. And this important bone, the palatine bone that has a horizontal and a vertical part with an orbital plate and a pterygoid plate, this articulate with the sphenoid bone, and this becomes the sphenopalatine foramen, which sends up the sphenopalatine artery. But the problem that this where you get your nasal flap, and it's really lies the Vidian canal. So you have to go through that to get the Vidian nerve, which is a good landmark, as we can see. So this is the maxillary artery, the second part related to the pterygoid. lateral part in the pterygopalatine fossa, giving the descending palatine, and then it will enter here into the sphenopalatine artery and give again the posterior septal branch, which we use for the nasoseptal flap. So here is again another magnification to show you how the sphenopalatine artery is going to the middle meatus. So this is the nasal cavity. So again, this is to remind you, that's why in this appearance, this is where the Vidian canal is. It is at the floor, the lateral part of the floor of the sphenoid sinus. The other thing that happened that the vertical part of the carotid and the horizontal petrous again changed direction at the floor of the sphenoid sinus. So what is the transition? If you see, this is the sphenoid bone, this is the lingua. So we have a petrolingual ligament, and this is really the ligament which divides the vertical from the horizontal part. In fact, this is called cavernous segment, but as I told you, the true anatomy, it starts above the V2 rather than from the beginning. Now, what happened to the C6, which is the horizontal part? So the carotid canal enters the petrous bone down here. This is your inner ear. And you can see here the vertical part related below the third part, the third division of the trigeminal. And this is important for middle fossa approaches. Here is your geniculate ganglion and the formation of the Vidian nerve. So if we drill the quasi-rhomboid here, which is the petrous apex medial to the horizontal carotid, it takes you down to the prepontine and the posterior fossa. The other important part related to the carotid is the cavernous compartments. And just simply, they are quite complicated. Now they are more important in endoscopic surgery for extension of functioning pituitary adenoma, which you want to clear. So there is lateral to the carotid, medial to the carotid, and superior part and inferior part, because the inferior part is around the paraclival carotid here, as you can see in these views. And this is an endoscopic view, lateral to the carotid, where you see the V1 and related to the sixth nerve, as I showed you previously in the cavernous sinus. So this is how we went through the carotid in the skull base. If you carry the carotid upwards to the supraclinoid, you have the two rings, the proximal and distal rings. So, and they are eccentric, so they are not really parallel. So they are open, concentrically open laterally, and we have this carotid cave related to the strut that has been removed here. And we have the ophthalmic artery going to the optic canal, and we have this is the superior hypophyseal branch. So this is the first part, the supraclinoid carotid, which you need to deroof the optic nerve to get a good view for it. So what this is important for, we do tuberculum and plenum meningiomas, and it's important to keep the blood supply, which is the superior hypophyseal artery. And really the two good views to get that is either the endoscopic view, but also the anterior interhemispheric will give you a good view. When you do the pterional approach, your ipsilateral superior hypophyseal is away from you, and that's why you can have ischemia if you don't see, it's a blind spot. Paraclinoid aneurysm are important. We put them all together because when you are large, you don't know where they are arising for. But when they are small, you can have more or less these three divisions. Some comes from the superior hypophyseal origin, some comes from the ophthalmic origin, and rare ones come inside the carotid cave. You can either do a total clinoidectomy every time, or you can really tailor it. And all you need is just to remove the tip. In fact, the only ones that you may have to drill the strut is the carotid cave ones, which are very rare. But what is most important is the roofing of the optic canal. I cannot emphasize to you how it is important, because this is how you get position of the clip. Maybe less so for the last one, but it's very important. This is again to show you the superior hypophyseal branches are multiple. They give the stalk and also the chiasma, as you can see here. And this is why you need the space to put your clip. And this is another anatomical variations to show you the ophthalmic artery going below the optic nerve. So now this is a magnified view, and you can see this is all above the sphenoid sinus. Then the artery continues as ophthalmic artery into the orbit, and I won't cover the whole orbit, but you can see the two important arteries are the anterior and posterior ethmoidal artery. And this is starts behind the frontal sinus recess, and this is very near the optic nerve, as you can see here. one is obliquely and one is transverse. And just to remember the measurements, it is 24, 12, and 6 millimeters. So the transition, this is from the very front to the back. The transition here is behind the frontal sinus, while here it is between the planum and cribriform plate. So this arteries leaves the orbit, goes the superior nasal cavity, and enters the cranium again. So if we look upwards through the endonasal route, we can see them. So this is the posterior ethmoidal artery. This is the anterior, just behind the frontal sinus, as you can see here. And they enter the cranium, and this is important because they give the falcine branch, which is can connect to deep veins, and this is the dural AV fistula, which you will find it adjacent to the crista galli. And all you need is just to disconnect the vein, and you get a good control like that. The other part in the orbit is the venous drainage. This is the superior ophthalmic coming through the superior orbital fissure, but it's connected to the cavernous sinus. So if you have a carotico-cavernous fistula, you can see it dilated here. So this is just a glimpse of the anatomy of the orbit. And I have shown you that before. This is an AVM within the orbit around the ophthalmic artery. And it's not a dural fistula because it's draining here through the superior ophthalmic artery and not through the cranium. So this is an AVM of the orbit. So the last part of the talk related to transclival approaches, and we'll see what is the relationship. So the clivus have a superior third, the dorsum celli, where above the petrous apex, and the middle third, this is the jugular foramen, and a lower third with the hypoglossal nerve there. And the artery related to it, of course, is the basilar artery. And it's important for cases such as clival chordomas. And you can see here the window, and we will see the relationship to the sphenoid sinus. So we study the anatomical landmark in Cambridge. It's mainly to know where is your corridor to the transclival approach. If you see a clival chordoma and it's around the vertebral artery, so you know which part of the clivus you need to look at. And we go back to the floor of the sphenoid sinus, and you can see here the floor of the sphenoid sinus have a relationship to the vertebrobasilar junction and also the pontomedullary junction. So we will try to study this again. So if you can see here in this view, this is the sixth nerve. So the sixth nerve, if you drill the clivus here, you can injure it. So you want to find where is the sixth nerve away from your lesion if there is a distortion by the lesion. It's come from the pontomedullary junction. So then it goes here into the Dorello's canal, as you can see here. So we did this study both in cadavers and radiological. We had a few cadavers which we have scanned on the CT scan. And we find, despite the different variations, that the vertebrobasilar junction is really, really within a few millimeters of the floor of the sphenoid sinus. So this is, again, a very good landmark when you do clival chordomas. And we studied 100 subjects with MRI scan. We matched them on the sagittal views, and we measured the distance between the floor and the vertebrobasilar junction, and we correlated again with the pontomedullary junction. So the floor of the sphenoid sinus correlate with the vertebrobasilar junction. There is a little bit of variation due to the aeration of the sinus, but it is an accurate landmark. So in conclusion, the sphenoid sinus floor is another good landmark to the vertebrobasilar junction, which tells you where you are. If you have a scan that the chordoma is low, then you drill the clivus much below the sphenoid sinus. And also it will help you to identify where the sixth nerve, if it is obscured by a chordoma. And just to demonstrate it in few seconds, this is a case of a clival chordoma. You can see it going to the medial cavernous sinus, and it has an intradural extension around the basilar artery. And again, we drill the clivus, as you can see here, the bone is eroded more or less. And we can see now the paraclival carotid. This is the floor of the cella, this is the top below. And you can see the bone is already eroded, and with the chordoma emerging through the dura. There is a dural defect, which the chordomas are quite easy. As you can see, they are delivered easily because they are soft. And once we clear it, I promise you this is not more than another minute and a half of the video. And then we can look inside, we find the basilar artery. And on the sixth nerve, in this case, we did not have to find it at its origin because it was obvious here. Then we have to clear the chordoma from behind the upper part. And you can see this is the anterior inferior ICA, the ICA related to the 6 nerves, anterior inferior cerebellar artery. This is the basilar trunk. There is some adhesions with the chordoma with the basilar artery that is easy, can be resected and teased off. And we'll see in a minute, because just to show you the whole idea, is where this is here, the vertebrovascular artery, and it's in flush with the floor of the sphenoid sinus, which is a good anatomical landmark. This is the top of the basilar, superior cerebellar, and this is a bifurcation in the 2 posterior cerebral artery. And then we look laterally, this is the 6th nerve, and there is an extension, as we see in the medial cavernous sinus. We have already drilled the paraclival carotid, so we know where it is. And you can see behind the 6th nerve, so we open the top first, we clear the top of the clivus, and then we return back and we get the rest, you can see easily because we have control of the carotid. And at the end, we resect the dura and we have the 6th nerve exposed. So thank you very much for, I hope I got it in time, and thank you for listening to this talk.
Yeah, thank you. I think that you talked right on time. It's very informative talk, and it's very also informative in terms of correlating between the endoscopic anatomy and the open approaches, which is so clearly important to all of us, because the anatomy we learned during our medical school and during a neurosurgical training, it's all different now. It's all endoscopic, and the anatomy is distorted and in a different perspective, but it's the same anatomy. So thank you for talking about this anatomy in particular.